Okay, well, it's 6:32, so why don't we go ahead and get started. Welcome, everybody. This is actually the 22nd iteration of West Coast Fellow Conference, and really excited to have JC Leveque here and to introduce him. The cool thing about this is I actually met JC, I think, through this conference. I don't think we really had any communication prior to that. And when we started this up during COVID, one of the main sort of impetuses to do so is to try to build community out west. And obviously, it's done that, at least for me and JC, in addition to exposing our fellows to faculty that they weren't able to do so during the pandemic. So, really awesome to have him be one of our speakers. JC is the head of neurosurgery at Virginia Mason. We've heard from a couple of his orthopedic colleagues, so it's great to have him here. He went to medical school at Duke, but then did his residency and fellowship at Michigan. So he may have been signed stealing from you, Vanu, when you gave your talk. We'll have to see. I know him and Greg have cycling in common. He and I have skiing in common. So hope to hook up on the mountain one day. In addition to a bread maker, I think he also played the banjo. So a man of many talents. But a lot of his research has been centered on risk in surgical decision making, and he'll speak to some of that today. And so for the fellows who are on the call, pretty soon you're going to be making these decisions on your own. And it's hard to think of a more salient topic as you get ready to start your own practices and build out your own career. So JC, really appreciate it. I'm going to stop sharing my screen and turn it over to you.
Okay. Let me. All right. All right. Thank you all. Yes, I think I'd like to talk today a little bit about risk and what does it mean for patients versus surgeons. We are a surgical conference. Let's start with a case. This is a case that as fellows, when you guys are out in practice, you're going to see this routinely. Probably older patient here coming in with back pain, leg pain. And I didn't pick a glaring example of a really bad problem because often this is what you are going to see. Patient who says this is worse when I'm standing, this is better when I'm lying down. Small synovial cyst there on the left side, moderate to severe stenosis at a couple levels. And the decision that you're going to have to face is a question of, are you going to decompress this? Are you going to fuse this? Assuming that you're going to move ahead with operative treatment. Now, I think one of the things as a fellow that you perhaps are limited in is your clinic experience. Many of us during our training primarily spent our time in the OR. And so a lot of the decision making and thought processes that go into getting that patient into the OR may be less transparent to you. But these are the types of things that you're going to consider. You're going to look at the science. You're going to say, well, a fusion tends to have a better ODI and VAS outcome, more durable, less chance of a short-term failure. It is going to pay you more. Decompression may have the other side of the coin, perhaps less improvement in the ODI. Maybe this patient is going to have a decompression, but then need a fusion again in a month, in a year, in 2 years. However, no one could really argue that a decompression overall is going to be less invasive and have lower risk of complications versus the fusion that may be more invasive with a higher risk of complications. And so these are the decisions and questions that you are going to be having with your patient there in the room. So then we ask the question, well, which is the riskier procedure? We can go to the NS-QIP calculator. If we look at the lumbar fusion, if I plug in my age and, overall I'm in pretty good health. So this is what calculator tells me, that overall my risk for the fusion is lower perhaps than the average. Predicted length of hospital stay for 2.5 days. The discectomy or decompression is obviously lower risk. You see that I'm predicted to stay in the hospital only half a day, and overall most of those risks there are less than 1% to 2%. Now, for an unhealthy patient, we know, of course, that the risks will increase significantly. This is a patient who is on dialysis with renal failure, hypertension, et cetera. And so these things, I think, are fairly straightforward. And as surgeons, this is often how we think about the surgical decision making. So the question becomes, as you think about it from the patient side, do you want the decompression or the fusion? Do you not want either of these? And we have to understand that each side has its own biases. So in general, people have an action bias. We like to do something, right? When you're sitting in this traffic jam, you are so frustrated that you just want to move to another lane, even though you know statistically that that lane is going to have a worse outcome for you. But it is actually making a choice. And so I think for many patients, you will encounter, they say, I just feel like I need to do something. And so that's this action bias. And both patient and surgeon have this, right? If you're sitting there in the room saying, I just don't really have much I can offer you, it feels very dissatisfying. My partner, Raj Sethi, who's on the call, when he and I started together 15 years ago, I remember him telling me in clinic, I always have to give the patient something. Like I order an epidural or I order, some other test just to have something that I've given them. And that's an action bias, right? We also have loss aversion biases, whereby the pain of losing something is far greater than the pleasure of winning it. So we view our losses fairly significantly and our gains less so, right? And we think about this in terms of sunken costs, right? So if you have $40 in your wallet, and as a Michigan guy, maybe I would have bought a Michigan ticket to watch them steal the signs. So I now have a ticket worth $20 and a $20 bill. If I lose the ticket on the way to the game, many people are not going to be willing to buy another ticket, right? They're going to say, wait, I already bought the ticket. I've spent the $20. Now all I have is $20 left. To them, it feels like a $40 ticket, right? I already bought it once and I got to buy it again. Versus if I have $40 in my wallet, if I lose a $20 bill, when I get to the game and open it up, I pull out a $20 bill. I'm like, well, I lost the other one. Well, I guess I'll still buy the ticket. It feels like a $20 ticket at this point, right? Mathematically, these are exactly the same. You have ended up with theoretically a ticket and $0, but the way in which you get there is very different. And so when we think about this patient who's going for the discectomy versus the fusion, one patient may say, I'm willing to have the discectomy, understanding it might fail because I would rather have the smaller procedure and then go on to the bigger procedure. Another patient may say, if I have the discectomy and it doesn't work, I will feel like I have lost, and then I will need to go on to the fusion. Those are the same outcome, discectomy, success, then failure, on to fusion, but the way in which the patient is approaching it is a sunken cost issue. And so understanding that difference between the patients may be partly the way in which you get to patient measure of satisfaction or success. So when we think about the surgeon's perspective, what's the risk, right? We think about these things. So actually this image on the left is I plugged the words failed spine surgery into an AI image generator. And this is what came up, which to me is such a perfect example with the dollar sign in the spines. But so we think, right? We think about the risk of infection, the risk of nerve injury, the risk of we are talking about complications when we think about risk. And there's a lot of work that has been done thinking about, well, as surgeons ourselves, how do we play into this risk? So if you look at surgeon personality, each one of us, and I think all of you as fellows, if you think about your co-residents or co-fellows, you can identify people who are more risk takers or aggressive versus those who are not. And so you can see that there's this risk attitude that was done going all the way from I enjoy taking risks to I rarely if ever take risks. And this has been applied to decision making. So this article looking at a survey of Swedish orthopedic surgeons, they presented 5 scenarios. You can see there in the bottom left. They basically go from a fairly healthy patient to a sick patient. And you see that as you go from a healthy patient onto a sick patient, more surgeons move to a less risky operation all the way to non-operative treatment. This makes sense to us. The question became, is the surgeon personality influencing how aggressive someone wants to be in making this decision? And so the airline industry has done a fair amount of work on this, looking at personality factors feeding into pilot performance. And so this column-headed aviation here, this is a survey measure that is given to pilots, and it is tied to an attitude listed there on the left. And basically what happened was these authors turned this over into orthopedic ease. So I'm a pilot due entirely to my hard work and ability, became I am a surgeon due entirely to my own hard work and ability. And they administered this survey to the same group of surgeons. And what they found was that there was definitely some distribution of hazardous attitudes. And you can see here that there was a spread of people throughout all this. And sorry, hold on, guys. Okay, yeah. So in the end, what they determined was that there actually was not much of an association between risk aversion and tendency to avoid surgery, but those with a macho attitude were more likely to recommend surgery. And macho, as you can see here, is I like to practice stalls, or I like to do challenging procedures. I like to do challenging operations. I like high risk operations. So those surgeons who tended to say yes to those categories were more likely to think about recommending surgical options. Interestingly, the choice of non-operative treatment was associated with the length of time you'd been a surgeon. So as those of us get grayer, we're more likely to say, I don't think that this is in your best interest to move ahead with surgery. When this has been looked at regarding reoperation or readmission, this same hazardous attitude has been applied. And what you can see here is that the airline industry takes the same attitude and has a threshold by which they would say anyone above this threshold they deem high risk or high hazard. And when administered to a group of surgeons, you can see that 30% of surgeons have at least one abnormally high hazardous attitude. So, from an airline industry standpoint, a third of us are dangerous. Now, we may argue that this is slightly different than the airline component, that perhaps we are dealing with different forces, that even though we like to compare the airline industry and surgery, these are very different fields. But I think the concept of how a surgeon's personality plays into this may have some bearing, especially when you see that the macho attitude accounted for 20% of the variance in reoperation and readmission rates. So you're taking on more challenging operations, but they do have a cost. And that might be a cost to the patient, the system, et cetera. So this comes back to, are you talking about doing a decompression or a fusion? Well, when we think about the patient's perspective, what does the patient value, and have they ever actually had to think about that before? And I think we would argue, as we started to think about this, yes, perhaps they have. So any of you who've ever sat down with a financial planner or taken a financial survey, walked into a bank, filled out questions like this: what degree of risk are you currently prepared to take with your financial decisions? Scenarios that present here, if you got $100,000, what would you do with it today? These are basically questions trying to assess, do you view yourself as a high risk or a low risk financial investor? And what comes out of this is that from the finance side, patient or persons can be broken down into thinking about they have a tolerance, a capacity, and a need. So the capacity is the degree to which you can tolerate a loss without it changing your lifestyle. If you've got this big bundle of money, you can lose some of it and you're probably going to be okay. Now, your tolerance, however, may be affected by your external circumstance. So if this is your family, now you may be a little bit less willing to lose some of that money because you have many mouths to feed. Finally, a need is the potential value of a particular outcome. If this is your scenario tomorrow morning when you wake up, some of those capacity and tolerances are going to have to adjust because you now have a critical need. And so patients, they have these same qualities. We just don't tend to think about them in this way. Here we've got, a college football player who has had an injury. This player is likely going to say, I'll take any risk if it means that I get to keep playing, because it's an all or none. They have a very high need and a very high tolerance, regardless of what their capacity may be. Versus this opera singer is going to say, when you speak to her about an ACDF versus a foraminotomy and the benefit or likely good outcome of each of those, is probably going to say, I need to preserve my singing voice. So I'm willing to tolerate some pain. I can live with that, but this is what I have a lower need overall for pain relief and a lower tolerance because I have things that I need to preserve. So where do we meet in the middle of this? So some surveys have been done looking at patient and surgeon preoperative expectations. So the white bars here are patient expects more than surgeon. The darker bars are surgeon expects more than patient, and the medium gray are they expect the same. So you can see that overall there are slight variabilities here in terms of the percent of cases that are going to have an improvement in back pain versus leg pain, and then return to work. Interestingly, as was demonstrated in the previous study, this does have an age effect. So you see here that the senior consultant on the left basically has a very minimal expectation that this operation is actually going to help compared to the resident who really thinks that they're going to make this patient better, right? And we have to understand as surgeons that our biases are playing into these decision-making processes. Now, when you look at risk-taking propensity, this survey was done looking at a general surgical group, a nurse, surgeon, and patient, and looking at the nurses that deal with patients who have a stoma, colorectal surgeons, and the patients undergoing these procedures, and looking at different scenarios, how much they would want to avoid a stoma or not. They administered a risk-taking index to all three groups. And what you see here on the right is overall surgeons are higher risk takers than patients or nurses, right? I mean, we've seen that in the previous studies. Interestingly, however, when all three groups were presented with a hazard gamble, which is basically how much of your life would you be willing to gamble in trade-off for a better outcome, surgeons were the most willing to gamble. Again, they are the greatest risk takers, but they were willing to gamble the least percentage of life. Patients were basically always willing to gamble away years of their life, because I think as surgeons and patients, we are entering into this discussion with a very different understanding and expectation. And this leads into this whole concept of an expectation actuality discrepancy, which is the difference between what the expected outcome and the actual outcome. And I think that when we think about the concept of patient satisfaction and patient and operation success, often we as surgeons may say, this was the expected outcome, this was the actual outcome. These are one and the same. You have a fusion. It is clearly arthrodesed and solid on follow-up x-rays. Everything is well decompressed. There were no complications. You were in the hospital for a short period of time. From my standpoint, everything has gone as planned, and the actual and expected are the same. Versus for the patient, these may be quite disparate. They may have had expectations that were not made apparent to us as surgeons, and so their satisfaction with the overall outcome may be quite different than our perception of it. So within our group here, we've started to think about how can we approach this as a means of understanding where patients are coming from. So we decided to start with a crowdsourcing methodology, looking at Amazon Mechanical Turk. This is basically a workforce of people who have signed up being willing to answer surveys online. It is a skewed population. It tends to skew younger, more educated. But we at least wanted to see, as we start to think about scenarios and risk-taking, is this a means by which we can start to determine the types of qualities that the general population is going to be thinking about as they approach surgery? So we presented a group of, quote, patients with these, here's one scenario. You have pain down your leg, making it difficult to sleep. Surgeon recommends surgery with a 90% chance of improvement. Sounds pretty good. 1 in 10 chance of risk of lifelong numbness in your leg. I think as surgeons would go, wow, 10% risk of numbness. I mean, that seems sort of high. Overall, almost everyone wanted to go ahead with this operation. When we changed this scenario from a 90% chance of improvement to only a 50% chance of improvement, and changed it from a 1 in 10 chance risk of numbness to a 1 in 10 chance of death, who would want to proceed with surgery? I think as surgeons, all of us would say, I have pain down my leg and I can't exercise, and you're telling me there's a 1 in 10 chance of death? Like, no operation that I do has a 1 in 10 chance of death. I do not want that operation. When administered to a general population, what we found was only 13 people changed their minds. So now, of course, this is biased. These are not patients in pain, but I think I would argue, actually, these aren't even patients in pain. Our patients in pain are probably even willing to take on more risk. And I think those of us who have talked to patients, many of them, when you say, they may ask, well, what's the risk of some complication? And when you say, well, there's a 7% risk of reoperation, they're like, oh, well, that's nothing. I'm like, well, hold on a moment. I mean, that's actually like 1 in 15 people. If I do 15 of these operations, someone's going to need this. But I think there is a a disconnect between how we are thinking about this and how patients are, even in this concept of shared decision making. So, what does this mean? Well, I think it means that people don't understand statistics, right? I also think that as surgeons, we are risk takers, but we really don't want to see the negative outcomes of those risks. Versus as patients, they value different things than we as surgeons. And there is data out there that demonstrates that complications may have little effect on the overall sense of satisfaction or success from patients. So then it comes down to, are there some demographic differences in surgery, those who want to go ahead versus those who do not? And is there any link between risk-taking indices and those who want to go ahead with surgery versus not? So our goal in thinking about this is when patients come in and we are presented with this image on the left and this form that many of us use a version of this on the right, thinking about, mark your pain. These are all the things that we want to know about. Maybe the question that we need to be asking is, what do you value? Rank your outcomes. What matters to you most? I mean, some people will say, I want to be able to travel. What does that mean exactly? Is traveling via wheelchairs the same as traveling via walking? Which risks don't matter to you? I mean, I think for many of us, if we said you may have a risk that keeps you in the hospital for 5 extra days, from a health system standpoint, that is a big negative outcome. From a patient standpoint, I feel like half my patients want to stay in the hospital for 5 extra days just because they don't want to venture out into the rain. So then the question becomes, what is your risk aversion and or risk tolerance? And maybe we need to start thinking about saying, here is what patients with your MRI tend to do. We need to start thinking about what decision do other patients who have the same risk attitudes and goals as you, how do they tend to proceed? And for the youngers of you, this is basically the Harry Potter sorting hat. You put the hat on the head and it tells you this is who you are, this is the group that you're put into. I think, for someone of my age, this is probably more my profile, right? I mean, I listen to Spotify and Spotify dials up mixes for me based on what I've listened to. It says, this is what you would like. This is what people like you tend to like. So if I'm a patient coming in with a particular MRI, pain, etc., being told this is what a 51-year-old guy who's active, who has this is what tends to lead to the most satisfaction, may be beneficial in terms of you as a surgeon thinking about it. And this has started to enter a little bit more into the field. This Journal of Personalized Medicine last year had a special issue thinking about personalized spine surgery. Now, most of these are focusing on hardware solutions, right? You see 3D printing, patient-specific guides, patient-specific implants. And our fellow last year, Jesse Shen, was the first author on this article, very much along the same lines. Think about personalized medicine, right? Normative spinal alignment, understanding the patient not just as part of a large group, but actually a subset. What is your Lenkey curve? Are you a high PI, low PI patient? How do we think about what we need to do in terms of correction, overcorrection, undercorrection, et cetera? Surgical planning software clearly has come into play in terms of thinking about compensatory changes, how one operation may lead to an increase or decrease in another operation needing to be done. 3D printing has opened the world to be able to customize implants, et cetera, patient-specific pre-contoured rods we've heard about. And then, here at Virginia Mason, obviously our multidisciplinary evaluation, thinking about the patient individually where they are. The question then becomes, as we think about this updated version of personalized spine surgery, maybe we need to start thinking about patients' personality, not only their medical background, their demographics, where do they live? How hard is it for them to get to care? Patient who has to, a fusion patient is probably going to need greater follow-up than a discectomy patient in terms of follow-up x-rays, imaging, et cetera. That may be a barrier to them choosing that as an option for surgery. What is their overall level of disability with which they're entering into the surgical process? And what's their overall general risk and behavioral profile? All right. Thank you, guys.
Awesome, JC.
Yeah, great perspective. Super helpful for us all to be paying attention to those dynamics.
Hey, this is
Go for Ryan.
Yeah, open up the questions, please.
yeah, I had a quick question. Sorry, I'm Ryan. I'm one of the fellows here. Is there anything research in looking at what you can to change your own inherent risk profile from becoming like an aggressive to more cautious surgeon or cautious to aggressive, vice versa?
I would say that in my experience, it's the old shine a light on it, right? I think that this is a scenario where M&M, where having some sort of group evaluation of patients going into surgery, the outcomes of surgery are helpful. I think that we all know that surgeons individually can be phenomenal, but I do think that there's a tunnel vision effect whereby surgeons working in a sort of solo practice where they don't have interaction with other providers, also non-operative providers, really run the risk of becoming their own best support and thinking that everything is turns out great.
Echo chamber.
Yeah.
So in your clinic, JC, are you performing any kind of evaluation on patients to better understand like their risk appetite and where they might fall in that, sort of spectrum of patient preference?
Conceptually, yes. Physically, no. I mean, I think we're sort of in the early process of this. I think part of the reason I wanted to present this, we're sort of, tossing this around and think about how we're studying it, and just thought it would be interesting to see how other people have approached this. I do think that it plays into the teaching component and the training component in terms of, I think as fellows, we are, often the fellow is hesitant to challenge the senior surgeon. And as senior surgeons, we have our own biases, in terms of how we.
Yeah, that's great.
Can the rest of the crew mute yourself real quick?
Bob, I think.
No worries.
Let's just give another minute or so, and then we'll go from there.
All right. Yes, but I think we have not yet started to use this in a formal fashion.
Yeah, we prepped slides, so Ryan's jumping on. He's got the case.
Hey, Bob, can you mute yourself real quick?
Sorry about
that.
that.
I'm not taking control yet, so if you guys could share there.
Greg's going to shut him down.
It
looks like John maybe has a question from Arizona.
Very, very nice talk. Thank you. John Hurlbert, University of Arizona. I just trying to wrap this into my own personal experience. One of the problem I see with a psychometric exercise like this is that in certain circumstances, maybe many circumstances,
we're just finishing up our fellows conference.
Patients' expectations change.
Conferences left and right.
Yeah.
And particularly when I look at my myelopathy group, post-op cervical myelopathy.
Yeah.
I think if you want to just go ahead and get started, just so you can get done, that would be great.
I have to really go back and remind them of why they were having the surgery in the first place, and try and readjust their expectations back to what we had talked about pre-op. So I wonder if that's a problem with pain-related procedures too.
Yeah, I think so. And, one of those papers in that Journal of Personalized Surgery looked at patient outcomes when patients were shown their preoperative surveys once again, and having an understanding, the further away that patients got from that pre-surgical evaluation, the less they actually remembered how bad they were. I mean, I think we've all experienced that. One thing that we have begun to use, to Hani's point of implementation, many of us here use a product called Medical Memory. It records the visit for patients, as a video, and then they have it. They can show it to family, et cetera, and it does it in a HIPAA compliant fashion. And I've actually found that helpful because you have a record of it then. Yeah. And later on, that record is available for me and the patient to see. And when I've used that, if I've had patients who are like, I'm just not really sure that I'm all that much better, And I'm sitting there saying, I think you're quite a bit better. Why don't we go back? Why don't you watch that video from, 6 months ago when you came in? You are doing much better than you were. But I think that you're right. There is a bias in terms of forgetfulness.
Hani, I have a question for you. This is Raj. Can you hear me?
Yeah, absolutely, Raj.
So, Hani, there's this. I think JC has made some very, very clear and excellent points for us to personalize spine surgery more. I think the predictive analytics work is trying to do the same thing, right? But yet, none of us are using. I mean, are you using any predictive analytic tools in your clinics in San Diego?
Well, there's not. I mean, to my knowledge, are there any that are really clinically available at this point?
Exactly.
Well, sort of the NS.
The only one is
Go
the
ahead, Raj.
NISQIP one, right? The only one is the NISQIP one. And so what we need to do is, and I think JC's leading a lot of this work at Virginia Mason, is we need to study what we can bring to you so that you'll actually use it in your group. You'll use it in your clinics, because I bring up the predictive analytics example because it's purely an academic topic, right? It's not something that is readily available to all of our surgeons. And so we need to come up with, similar to that Swedish orthopedic surgeon study that JC showed, something that we can bring to the point of care or to people to, as one of your fellows recently mentioned, how can you change surgeon behavior, or how can you actually personalize the experience? Because, to JC's point, you have a 50-year-old guy who is active and wants to be even more active. He's going to want something different from an operation than the dialysis dependent wheelchair 50-year-old, right? And we pretty much right now sticker tape the same procedure to both of them. And so I think it's really, really important. JC, I have a question for you too.
Yep.
What do you think if you administered one of these questionnaires to that solo surgeon who didn't have non-operative specialists, who wasn't part of a team? Do you actually think that he or she would change?
If I look at what we often believe is the worst case scenario of that type of surgeon, I don't think that they would think they need to change. So given that they don't feel that they need to change, I don't think that they would.
Yeah, and so I think that's an interesting cultural discussion about surgeons and about our culture, which is, I think, very different than the culture of aviation, the culture that pilots have, which is, essentially a lot more regulated. So if we go forward, 10, 15 years, maybe that's going to change. I would hope so.
Yeah. Well, I think, to a certain degree within the airline example, there is theoretically a best outcome for each scenario, right? There's a right answer. And I think that unfortunately in our situation, there's not always the right answer. There's theoretically the right answer for that patient, but even that is up for debate, because the right answer surgically in terms of radiographic outcomes may be different than risk of patient complication, et cetera. And so that's where it starts to fall apart a little bit. And I think that's what you're getting to, Raj.
Agree.
Yeah.
Hani, do you have a minute for a
Dr.
question? Hi, JC. That was a great talk. And
Thank you.
Just wanted to bring up a old question from an old man. I think the decision of final decision, I think there's no question there's a great science behind this, and one day you can probably get to the bottom of this and really select the right surgery for the right patient without that much giving thoughts. But so all this, the influence of patients on surgeon or the surgeon decision making has been a concern for a long time. And I see that you're becoming more and more, trying to find the solution, which is great. I think the question I have is, at the end of the day, when you influence all the factors in character of the surgeon, desire of the patient, economics, and so on, what would be the final way to pick up the right surgery that you would do to your sister, to your mother, and your family. And I think that's the, regardless of how much it costs, how much is, and the proper surgery. Is that some sort of an art of surgery and decision making plays into this?
I think so, and I think that the skill of the surgeon plays into it. I think in general, most medical professionals we know do not have a desire for extreme life-saving measures, right? So I think most of us here on the call, if our family member, if our mom became exceedingly ill and was in an ICU, we are much more inclined to say, I do not want to, do anything aggressive. Life should take its course. We know that patients do not have those same feelings. That that's been studied, that in general medical professionals are much less likely to undertake extreme life-saving measures. So I think that there is some disconnect, and you're exactly right. Patients do ask, if this were your mom, what would you do? Would you do this operation or not? And I think that that's a fair question, but we need to understand that even in your answer, you're as a professional and knowing what you know,
Bias.
you have a bias, and it's look, you have the most information, right, of anyone there in the room in terms of what is the most possible or most likely outcome. So from a knowledge standpoint, you have the right answer. But when you say, I would not do the operation, or I would do the operation, if the patient is not meeting you at that point, then that may be an operation doomed to not necessarily failure, but a lack of success. And I think trying to figure out how we can get both the surgeon and the patient to the right point is, to me, the holy grail.
Yeah.
Thank you.
Thanks again, JC. It's 7:09, so we'll end it here so people can get to the OR and get on with their day.
Thanks, honey.
Have a great weekend, everyone, and look forward to catching up with you all soon.
Thanks.
Bye-bye.
Thanks, JC. So isn't a lot of this trying to help people have an EQ?
Yeah. I mean, right?
We're basically trying to quantify EQ, right?
Yeah.
And then how do you adapt to have a reasonable EQ to help you with decision making, right? Because a lot of
Greg,
really.
Can I ask you a question? Can I ask you a question?
Yeah.
Can you teach emotional intelligence?
That's no, and I think that's the issue.
Yeah.
But can you have EQ where you can relate to somebody and have a great relationship, but also maybe not understand the risk calculations that you're making versus what they're making? You know what I mean? There's multiple facets to EQ. And
I think some of this, if you had an endless amount of time and you spent hours with each patient, you could probably get to a better point, right? But I know that patients come from far away, I can look and be like, oh, you came from over the pass, that it's hard to get here. But I don't know. Overall, the wealth here in Seattle is very different than the wealth in Yakima, or in Eastern Washington. So I've had some patients who say, oh, I'll drive over, no problem. Sure, I can take the day off and come over. Other patients who go, oh, yeah, no, I can't. If I need to come back for visits, I can't come. Unless they're generating those statements, I think it's a lot to ask us to go through and assess all of these different components and qualities. And so I'm hoping that we can have some sort of survey or assessment that partly gets to the bottom of that in a more standardized fashion.
That would be huge.
Yeah. I still so one of my buddies has the largest painting company in the United States. He only does primary paint jobs. Ram Stadium, Stanford. He's currently taking on the San Diego airport remodel. Big time guy. He got into painting because he needed a job in college. And by the time he was a junior in college, he quit school because his business was booming. Because when he was painting, he recognized one thing: painters were always late and they never finished the time that they said they would finish. And he made it, he said, I'm going to finish on time every time, period. And if anyone eats the cost, I do. So he took this responsibility and then started this job. And it's just like, 20 years of like slugging, but like the last 20 years, I mean, the guy's got more Ferraris than but when I talked to him, I realized it's not just that. Like he probably doesn't know anything about paint anymore. He's just the freaking smartest EQ in the room. So when he's doing contract negotiations for the San Diego airport, he's able to relate to people the way no one else can. The way he imparts how other people feel, like they feel good around him and they want to work with him. I think that exists in our field, where there are certain surgeons that are just able to connect with a larger number of patients. And I may tell the patient the right answer. You need a T4 to ileum with an L4 to PSO. It's a massive operation. It's the right surgery, But because I can relate with that patient and communicate that, they feel comfortable with me. Now, the other surgeon, who's actually a better surgeon than me, it has a crappy EQ, tells them you need a T4 to ileum, right? And they're like, no way am I having that operation with you. Yet that guy is like way better than me. Like there's a major disconnect there, right? And the EQ of the surgeon, like, and we see it, right? We see these guys that are like insanely intelligent and their practices are rampant and they're horrible operators, right? Like they cannot operate their way out of I don't know what the saying is, like whatever, right? Like yeah, thank you. So anyways, my there's not just the EQ outwards, but there's also the introspective element where you say, all right, as a surgeon, what are my limitations? What do I need them to be? What can I accomplish? What can I safely tell these patients? And I think there's a very big lack of introspection in our field as well. So
yeah, but Greg, I'd be interested in Bruce's thoughts on this if he's still on the call. I feel like that's something that has changed a bit over the decades, right? I feel like when it was the start of my training, there was much more a sense of there's the person who is the expert in the field, and it doesn't really matter what their personality is. They're just the one who can get the job done the best. Like people sort of wanted the best. Versus now, I do think, as you're saying, I hear many more patients now talk to me about, oh, I saw someone and their plan seemed very reasonable, but I just didn't like their bedside manner. Versus at the start of my training, I would hear the horror stories of bedside manner, but it was, oh yeah, the guy had a horrible bedside manner, but he was the best, and that's where I was told I needed to go. And I think that there's been a shift in patient expectation on that.
Yeah, I agree that this is an issue that comes from somebody who is really good. I mean, imagine I had that experience before. What is a charlatan? And it's, you don't want that surgeon do your surgery, because that it's the surgeon that I replaced 42 years ago was the surgeon who was treated the patients of 100, 110, 120 degrees by just resecting the rib hump, no fusion. And the patients were very happy. And even after the curve progressed to 200, then the patient would come to me and said, he was great. He did a great job.
Yeah.
And now you have to fix this, shit. And so, that definitely, how can you avoid that? And to recognize that with this patient who is nice, has that relationship with the patients, a great Mondays that comes and talks, and patients love him, but maybe there's another patient is like very rigid and just maybe a little bit better surgeon technically, and I personally love to have a relationship with it. I like to see and trust that patient, that doctor. So it's sort of a spectrum of all these, so finding the right doctor that do the right surgery for your family comes to my mind.
I also think to take that to the next level, Dr. A, back in the day, there were scoliosis experts that did deformity surgery, and then there were those that didn't, and technology, enabling technology, personalized medicine, all this stuff really has, instead of making it more black and white, has now added a insane amount of gray. And in that gray zone, I think surgeons perceive themselves we always perceive ourselves better than we should. Always. That's a no-brainer. But I think it's gotten to a much further, like, it used to be like, if you put pedicle screws in, like, you were very unique, right? That was a very unique skill set. And then industry reimbursement, once we got past litigation, we realized, it's a great tool. It yields better fusions. And then now, pedicle screws are like, it's not a big deal anymore, right? Like in residency for me 20 years ago, it still was a big deal. And now it's like, that's not the big deal anymore. So I think what's happened a little bit is that the playing field has been leveled a lot more. So yeah, when it comes to 100 degree curves, people are going to be pretty uncomfortable. But when it comes to 25 to 50 degree curves, I think everyone feels that they're the expert in that field and can do that surgery successfully. So this concept of the expert is out there, I don't think is there as much anymore, because surgeons in the community are feeling much more comfortable being able to instrument a spine, even if they can't correct the deformity.
And Greg, I totally agree with you. And to add to your point, which I think is very clear, the industry wants to, quote unquote, democratize spine surgery, right?
Yes,
so the
100%.
reason they're willing to put that machine in your operating room for free with a quote unquote earnout is they want to democratize surgery. And the problem is, at least in adult scoliosis, and I think you and I both know this, is it's much more than just pedicle screws, right? It's all the stuff that happens before. It's a lot of the stuff that happens during, and it's a lot of the stuff that happens after. And so the industry, I don't know, cares as much about that. They just want more pedicle screws being put in. And so we got to be really cognizant of a lot of the factors that JC talked about and what Behruz just said, which is that, being able to look at these surgeon personalities and if there is some way to shine light, I agree with you. We can't teach emotional intelligence. But potentially we could teach something called surgical intelligence, where people are able to look at themselves in the mirror. They're able to look at the type of pathology and say, hey, I'm going to send this one on,
Yeah. That's the trick. And a lot of time, like I was talking, a lot, even my partners, you do like 8 real deformities a year. And let's say you're not a great deformity surgeon. And let's say that yields a 50% complication rate. All right. Like a major complication rate. Well, that's 4 out of the 8 for the year. That's 1 every quarter. And the impact of that is probably not significant enough in the scope of the entire year of the 250 surgeries that you do to feel like you're not that good at that operation. Right.
Mm-hmm.
When you go deformity only, and you do 150 to 200 deformities a year, which is currently what I'm doing, and you have a complication rate of 20%, which is arguably low, it's devastating, because it is 3 times a month, sometimes 4, that I have a major complication I'm dealing with emotionally, personally, with the patient, with their family, with my family. And you see how hard it is, because you live it. But if you're only dabbling, I don't think you perceive. And then the other 4 are like super happy, right?
Right.
They're stabilized, their deformity's good. You're not a great deformity technician, but you got them close enough that the patients are happy, which happens a lot, right? Then you feel really good about yourself. So it's like, it's this bias that exists even within the practice and
Yeah.
So I think that's
I've never
also
heard it put that
why.
way. I've never heard it put that way. That's a very interesting thought experiment.
Yeah, I mean, Greg, this is a really, a long-term issue for us as we get older. So, I'm around the age of 50, and that's all pretty much majority of what I do. 90+% is adult deformity, and you have these complications that you're going to have them no matter how good we get, and they weigh on your mind, they weigh on your personal professional life. And if you do it 4 times or 8 times a year, to your point, you're not going to feel, you may not get that. Also, the other side of this is the cumulative hits to your own state as you get older and older and older. And again, this is something where Dr. Barnia has a lot more experience at being a pioneer in the field of scoliosis than us. You guys had a smaller support group. You didn't have as much industry support vis-a-vis enabling technology. And Behrooz, you wrote an article in 2007 or 2008, degenerative scoliosis, to operate or not. And
Yeah.
I had that slide in a lot of my decks early on because, it used to be, when we started, JC, myself, Greg, when we all started, it was, well, maybe you shouldn't even operate on adult scoliosis. And now that's not even an issue. Now you should operate on adult scoliosis, right? And, you guys dealt with a lot of angst around these types of topics that now, because it's more democratized and it's not based in certain centers and you can treat scoliosis out in the hinterlands, this experience will be very, very different, I think, in the coming years. Behrooz, what do you think?
Yeah, I think that you're true. As we get better with technology, with data that would support our decision making, obviously we're more confident. There's no question about it. And so I think we have to stick to our principles, no matter how progress and how much progress we have made. So these data help us to make that decisions. Thank
All
you
right,
so
guys.
much.
Yep.
Love
Thanks,
you.
guys.
You have a
Guys,
great
good comment.
Friday and great weekend.
Bye, JC.
All right.
Thanks
Bye,
again, JC.
Bye.
Later, guys.
Yep.
Behrooz, nice to see you. Bye-bye.
Good to see you. Thanks.